Okay. So we're going to move on to our second presentation. This is going to be a presentation by Dr. Fraser Simmons, Professor and Director of Research Operations in the Department of Pathology at University of Texas MD Anderson Cancer Center in Houston. He's going to talk to us about residual cancer burden after neoadjuvant therapy and long-term survival outcomes in breast cancer, a multi-center pooled analysis.
Thanks, Virginia, and thanks for the opportunity to participate in today's press session. So you've heard the title. I just do want to highlight our disclosures. We did receive a patent for the mathematical formula behind the residual cancer burden many years ago, and that residual cancer burden has always been... Thank you, sorry. So just with respect to disclosures, we did receive a patent for the mathematical formula for the residual cancer burden about 11 years ago. And from the very beginning, the residual cancer burden has been a freely and publicly available website tool and will continue to be so. So I just wanted to clarify that. Okay, so this is really about organizing the workflow in pathology to standardize the way we evaluate response after several months of neoadjuvant treatment. And all of these data relate to post-chemotherapy response. And the basic principle is that we estimate the area that still contains residual disease, map that area to the slides that we'll be looking at in the under the microscope, and create an image so that we can really reconstruct it, and then be able to determine what area still contains actual cancer under the microscope. And then we combine that with the fraction of that area that still contains cancer cells that are invasive, as well as the number of positive lymph nodes and the size of the largest metastasis. So there's no special testing here. This is just organizing what we would otherwise report anyway in pathology, but doing it in a quantitative and standardized manner. And the website, you enter these six variables, and you hit calculate, and you get a residual cancer burden score, where 0 would be a pathologic complete response, i.e. no cancer left, and in any increasing score above 0 means there's some cancer left. And that is then categorized into a class. There are 3 classes, 1, 2, and 3, minimal, moderate, and extensive disease. The website calculator page gets visited quite frequently. It's just breached 16,000 visits per month. So it's being used out there. We don't know how many patients that actually affects because it could be visited multiple times per patient experience. But it is being used, and the website has instructional videos and educational materials and protocols and illustrations and the diagrams I showed on the previous slide to really be there as a resource for pathologists who are using this or training people how to use it. So the purpose of this study was a multi-institutional pooled analysis. It was really led by ourselves and Laura Esserman, who leads the I-SPY consortium, which we participate very actively together. And Laura's in the room here if there's any questions in the discussion. And so we identified sites and convened sites that we knew had an experience with this. And 2 of those sites, the I-SPY is a prospective trial. That's the only one that's really using it prospectively, collecting it prospectively in their trial. And the Cancer Research UK Artemis randomized trial did a central review of RCB. And so there's 2 trials embedded within this consortium of 5,160 patients' responses. Sort of the headline result here, the most interesting result, to my opinion, is that when you look at the residual cancer burden index score, as we're showing on the x-axis, and you look at a function of survival, or in this case it's the risk, on the y-axis, it's plotted on a log scale, you can see a log linear relationship here. Now the implication of this result is that you can take an individual patient's score of how much residual cancer burden they have and calibrate that to an accurate estimate of their risk over time. And the scale on the y-axis, as I said, is on a log scale. It's the relative risk of an event relative to patients who had a pathologic complete response, who had a complete, had no disease left. So the classes of residual cancer burden are shown in this plot by the vertical cutoffs, and the classes are indicated at the top of the graph. These classes stratify risk in terms of event-free survival and distant relapse-free survival, almost identical results. So we pretty much just carried on with event-free survival as proof of principle for the further analyses, which is to look at the subtypes of disease. And when we look in triple-negative breast cancer, which this audience knows is the most naturally aggressive form of breast cancer, we see the classes clearly and strongly separating future prognostic risk. But I will point out that the format of the tables we're showing in the subtypes have the frequency in the white rows, the 5-year event-free survival estimate and confidence interval in the grey rows, and the 10-year estimates in the black rows. And so one of the points here is that about half the patients get a PCR or an RCB1. In this case, it's 55% in this series. But we did find in this large meta-analysis that there was a lower survival probability in the RCB1 compared to the PCR in triple-negative breast cancer. In hormone receptor negative, HER2 positive breast cancer, the patients who received HER2 targeted therapy as part of their neoadjuvant treatment, we see a couple of striking findings. First of all, nearly 70% of these patients had a pathologic complete response, just really illustrating how effective these current treatments are. And the 20% of patients who had an RCB2 in grey or an RCB3 in red have a significantly worse survival than the rest. So a small quintile of patients still at fairly substantial risk. And when we look at hormone receptor positive, HER2 positive breast cancer, again we see the RCB classes are stratifying the risk. It's quite the interesting point to note here, I think, is that the RCB1, the yellow curve, really track with complete response for approximately 5 years. And then there are some later events that we observed in this population. And in hormone receptor positive, HER2 negative breast cancer, where I think there still remains a bit of residual confusion about whether or not chemotherapy can help patients with this type of disease, we see that the extent of residual disease is strongly prognostic. So there's clearly an effect on prognosis from the chemotherapy, but the most prognostic aspects of the distribution of response are when there's the most residual disease, the RCB3 in red and the RCB2 in grey. And it's a long-term risk that's still continuing beyond 10 years. And returning to this continuous relationship with the log of risk, we can see in each of the subtypes, in the order that I presented them from left to right, triple negative, hormone receptor negative, HER2 positive, hormone receptor positive, HER2 positive, and on the farthest right, hormone receptor positive, HER2 negative, we see that strong relationship with risk is very clear in each and every subtype of disease. Look how perfectly linear that risk curve, that log linear risk curve is for the triple negative at left, and very tight confidence intervals around those risk estimates. On the farthest right, the hormone receptor positive, HER2 negative, this is the group where you get a slight sway to the right on the curve rather than a true diagonal linear effect. And we're interpreting that as the influence of adjuvant endocrine treatment, but that will obviously deserve further study. And so in multivariate analysis with pre-treatment clinical and pathologic parameters, we learned the following, that in each of the subtypes, residual cancer burden index was independently significant, that a small minority of patients who present with T4 extensive disease in the breast still remain at significant risk independently. They're a small group, but it's a dangerous group. And that in hormone receptor positive, HER2 negative, pink on the farthest right, that the clinical nodal status before treatment and the histologic grade of the tumour continue to add independent prognostic information. And in the triple negative breast cancer, blue on the farthest left, you can see that compared to the T2 presentation, the T3, the larger tumor size still adds some additional independent risk to the multivariate model. So to conclude, the prognostic association of residual cancer burden, both the index score and the class, was generalizable across a very large multi-center pooled analysis. And I didn't show these data, but they're in the presentation. It adds prognostic information to the stage categories. Residual cancer burden was prognostic in each phenotypic subtype of disease. It's independent of pretreatment clinical and pathologic information. And we also just want to highlight hormone receptor positive, HER2 negative. Some of these pretreatment clinical characteristics remain prognostic. But the most important conclusion in my mind for the here and now is that there's a strong potential to calibrate an individual's residual cancer burden index score to her residual prognostic risk. There is a generally linear relationship between RCB index value and the log of risk, and that it is, as we've demonstrated, it is entirely feasible to have phenotype-specific calibration risk curves for use in the communication of risk and the interpretation of clinical trials. Thank you.
We'll take questions, and I'll ask the first one. Every patient, even the hormone receptor positive patients, received chemotherapy neoadjuvantly?
Yes,
And
all the chemotherapy.
And every HER2 positive patient received trastuzumab plus potentially other anti-HER2 agents?
In the pooled analysis, there's about 10 to 20% of patients who did not, and we excluded those for the analysis of the HER2 positive subsets. So we focused only on the patients who got HER2 targeted treatment with their chemotherapy in the neoadjuvant setting.
And there was no control for whether they received post-neoadjuvant therapy besides the endocrine therapy, maybe more chemotherapy, more anti-HER2 therapy?
We collected that information and we excluded any patient who got post-surgical chemotherapy.
Oh, okay. Go ahead.
MariceWeiss, This is the group of patients, the ones who have residual disease, who really feel the worst that they flunked the test of their neoadjuvant therapy or whatever, and who may be the most motivated to participate in clinical trials. And the question is, how much access is there to clinical trials? How many are available for that cohort of patients who do have residual disease after?
Right. I'm a pathologist, but I'm aware of what's going on in the clinical trial space, and Virginia can certainly chime in with expertise. I think, first of all, I think that an accurate and reasonably quantitative estimate of risk is probably helpful for anybody in the decision-making process most of the time. We have seen a dramatic shift in the last really 3 to 5 years towards post-neoadjuvant trials based on elements of perceived residual risk, usually the pathologic size of the tumor and nodal status. And we have seen in recent times FDA approval of novel therapies in this setting. So I think that actually at the current time there are clinical trials in every subtype of disease that one can participate in. I think the secondary question is, could we be doing more in the clinical trial space? I think yes. And I think when we do that, we can do a better job of that by having more precise risk estimation from the standard of care. But then I think one of the things in today's session, in this morning's session, there'll be a series of talks about how we could maybe make estimates of what the response might be in the course of treatment and be able to make adjustments to the neoadjuvant setting in the having already started, and then adjust in a clinical trial setting. And the I-SPY group have a very active effort to make an adjustment to their clinical trial. They're calling it version 2.2, and other groups are doing the same, and some of them will be presenting their detection work as a series of talks this morning.
I would like to say that we have flunked our patients. The patients, unfortunately, have done the best they can. We need to do better. But we do have trials, and you've seen some of them being presented at this meeting with post-neoadjuvant non-PCR patients being randomized to more therapy, and there are many ongoing as well with immunotherapy too, which I think is going to be a very interesting group of patients. So this is this is what I think Fraser's RCB is really powerful, because it helps us design the trials where we can minimize treatment on the patients that potentially don't need any more, and we can maximize it on the patients that need a lot more than what we've already given them.
And you minimize it in the people who are not going to get benefit,
Which is exactly. So do less and do more on the right kind of patient.
16,000 visits a month sounds like a lot of use. I'm just wondering, Dr. Kaklamani, and I see Dr. Rugo's up front, do you all use this in your practice, and do you think community oncologists are using it the way they did adjuvant online, for example?
I do. I ask my pathologist to give me the RCB score. So yes, I do. The question is, what do I do with the results? And it's a little limited. In the triple negative patients, I may consider giving capecitabine in the adjuvant setting, or obviously enrolling them on clinical trials. In my HER2 positive patients, I will look at the results from the Catherine trial, and I look at the results from the Extenet trial. To guide me. In my estrogen receptor positive patients, I'm still waiting for results from other trials to see how these results will be interpreted. What we've so far kind of looked at is that in many of the trials, achieving a pathologic complete response in ER positive patients may not be as important, but as you can see here, it looks like RCB really is.
Mm-hmm. Dr. Rugo, do you want to comment on, do you use this?
I'm at a sort of public institution at the University of California, where the sort of central organization.
I'm sorry to interrupt. Can I ask you to speak into the microphone? We have folks on the webcast that I'm sure would appreciate your comments.
And Laura obviously will be able to comment on this, but in the sort of medical oncology world, we have used this a lot now. And in fact, I think, the cellularity of residual disease, so how dense your cells are in residual disease, is something that oncologists really hadn't thought about very much. You either had a centimeter of disease left or you didn't. But now I think we're really able to put that into context in terms of outcome, and that will really affect how we treat our patients. I think in the post-neoadjuvant setting, being able to stratify is incredibly important to affect outcome, and also to minimize toxicity for patients who actually have a very good outcome despite having minimal residual disease.
So the I-SPY trial for 10 years says this is a standard, but prospectively moving forward, it's the standard of care. I think it's really one of the most important things that Fraser has done is he standardized a process for how to evaluate what's left at the end of chemotherapy and when someone goes to the operating room. And it's not just the readout or the cellularity, it's how you process the specimen. So if you take one section, you really can't do residual cancer burden. It's the idea that you're going to look through this in a very careful way. And these results, what we are hoping will change the Joint Commission standards for staging, that there will be a special section on what the standard should be for the care of women who've undergone neoadjuvant therapy. So there has to be a training and a commitment to using this in a consistent way so that we can all rely on the information. This is critical for our patients. And this is, as you say, Virginia, how we're going to get people to the best outcome, and to do it up front when we have the chance to still cure people. So I think it's really important, and it is standard in the 22 sites across the I-SPY trial, and with the reason we did this meta-analysis was to really change the Joint Commission, the AJCC staging, and we expect that that will happen on the basis of these results.
If I might add a brief comment to that, I think the question was very well placed, and I think the question could also be placed to the pathology community, because I think we're really at a state of transition, and this study is very important to demonstrate generalizability and sufficient size and precision to generate the evidence to convince the pathology community to slightly change the way we do things. And more specifically, when we have synoptic reporting, which is a requirement in pathology reporting in any type of cancer, we have one synoptic report for invasive cancer, and it's designed for the surgery first evaluation. We actually don't, at a national or international level, have a post-neoadjuvant synoptic report that specifically addresses the needs of the interpretation of the post-neoadjuvant response. And if we can get to a point where we bring about that change, then we can say what's evidence-based, what's the, we can always adapt it, adjust it, but can we make that transition, and with the realization that the neoadjuvant model is increasingly related to precision medicine and individual patient treatment strategy. So I think that's where we stand right at that transition. Thank you.
Thank you. So we'll